Hey, hi everybody. It's nice to be here. I'm going to change tacks a little bit, but a lot of what you've just heard in the last little while will feature fairly prominently, as you see when we talk about the clinical presentation. I'm not going to talk about cardiovascular disease in adults. That's usually what you would hear about is atherosclerotic disease as an adult disease, but I, as a pediatrician, I'm going to focus on the pediatric piece. And really what I'm going to talk to you a little bit about is a vascular coming-of-age story. So what is it that causes that progression from a normal vessel to one with atherosclerotic lesions? And so I'm really focusing on that transition, and I'm focusing on it very early in life for reasons that you will see. On the adult side, this is a landmark study that I brought up because it was headed out of McMaster. This is a study that basically took a very large number of adults with heart attacks and compared them to adults that did not have heart attacks. And you'll see the numbers, 15,000 cases and almost 15,000 controls in countries around the world. And what they did was measure the things that we know cause cardiovascular disease. And I think even to the surprise of the authors, they were able to identify 9 risk factors, modifiable risk factors, which is really important, that explain 90% of the population attributable risk for atherosclerotic cardiovascular disease. The emphasis on the modifiable is really important because people at the time that this study was undertaken were looking for strange and wonderful and new cardiovascular risk factors. And what they tried to emphasize here is we know what the risk factors are. We need to introduce interventions that function or impact those. And just to go through them quickly for you, this is not going to be new, I don't think, to anybody here. These are the risk factors that increase risk. You've heard about some of them already. Lipids, smoking, high blood pressure, a reported history of diabetes, abdominal obesity, and they had a very simple measure of psychosocial stress. Basically asked them if they'd ever experienced any of those things there, and were very surprised to see the power that that had in terms of predicting cardiovascular disease increase. What about on the protection side? Was there anything? Yes. Interestingly enough, fruit and vegetable consumption seemed to be protective. Remember, this is purely a cross-sectional study, so this doesn't necessarily mean that there is a fruit or a vegetable that is protecting from heart disease, but it tells you that there may be something about the pattern that individuals eat that is protecting them from cardiovascular disease. Physical activity, and interesting, alcohol consumption. Not super relevant to me in the pediatric side most of the time, except for some of my teenagers. But remember that this is any alcohol consumption, and it's important for you to know that binge drinking, in fact, actually is a cardiovascular risk factor. And it's something that you see very much when you look at multi-country studies, particularly those that are involving Eastern Europe and Russia, where there's a high prevalence of binge consumption in cardiovascular disease. Anyway, that's an aside, just to warn you guys. Friday night, take it easy. All right, so what relevance does any of this have to pediatrics? Well, we've known for a long time that kids can develop atherosclerotic cardiovascular disease. And we've known because of unfortunate young people like this 6-year-old girl here who has a homozygous mutation in the LDL receptor. Now, you've heard a lot about the LDL receptor today, and you could imagine that if you are unable to take cholesterol up into your cells because you don't have the LDL receptor, that your cholesterol level will be very high. Your LDL cholesterol will be very high. And it is. So your normal LDL cholesterol is up to about 3.3 or so. Varies a little bit with age. These kids have LDL cholesterol levels that are 5, 6, 7 times. And these little growths, if you will, that you see on her knees there, that's actually cholesterol deposits under the skin. And it's one of the earliest findings that we have for kids with homozygous FH. We have 4 or 5 of these children in our clinic. And the challenge for them is that they develop myocardial infarctions while they're still children. And some of them actually present with an MI, and they're trying to scratch their head trying to understand why they're not happening. Fortunately, it's relatively rare. It's about 1 in a million to have the homozygous form. But what is much more common, and what is the bulk of my lipid clinic, are individuals that have the heterozygous form. So they have one gene mutation, and that is very common, about 1 in 500 in the population at large. There are a few founder populations around the world. And what that means is that someone very early on had that mutation, and it has passed through these populations that are or were relatively isolated. The French-Canadian population in Quebec is one of them. There's a Dutch founder effect as well, and we also see in South Africa, in the Dutch population there, higher rates of heterozygous FH. Important to know, though, that these individuals also, they have high LDL levels. They're generally in the sort of 5 range, so about 2 times normal. And this is old data to show you what is the risk, the natural history of having heterozygous FH. And you'll see this is a fairly large study, and we're happy that we can't do this kind of study anymore because of the advent of statins to treat this condition. Dr. Austin showed you some graphs that looked at cardiovascular disease, and a lot of the large clinical trials have shown the positive impact that statins have in treating this disorder. At any rate, without them, the males start to have heart attacks in their 20s, and you see that they're relatively prevalent. In fact, 30% of them will have had an MI in their 30s untreated, and so those are very high prevalence rates for cardiovascular disease, and it raises important questions for all of us about screening and about the treatment of this disorder. So this is mostly what I deal with in the pediatric lipid clinic, where we do actually screen for and treat kids with heterozygous FH. Anyway, so we know atherosclerosis is a pediatric disorder, but it's a really early pediatric disorder. If you look at this, this is older data now, but this was some of the first data in fetuses and in infants that looked at the presence of actual atherosclerotic lesions, the fatty streak that Dr. Austin showed you, in babies whose mothers either had normal cholesterol levels or high cholesterol levels. And what you'll see here is that if the moms had high cholesterol levels, then the babies had higher extent of atherosclerosis, both as a fetus and as a 3-year-old. And this is something that woke a lot of people up to think about the sort of fetal or early origins of coronary artery disease. That's just to show you that the atherosclerotic process continues throughout life, and lesion sizes do increase over time, and they increase more rapidly with that particular risk factor. There are other risk factors that also accelerate the progression of atherosclerosis in kids. And this is data from the Bogalusa heart study. How many of you have heard of this study? This was a landmark study back in the 80s that really went and was one of the first epidemiological studies in the pediatric age group to try and measure cardiovascular risk factors in kids. And what they showed, this is a very large study in white and black children in Bogalusa County in Louisiana. And unfortunately, of the large group that they looked at, 93 children had died of an accident, and they had approval to look at their vessels, and they looked for both fatty streaks and fibrous plaques, and as you can see, looking on the left, the more cardiovascular risk factors that they had when they were living, definitely predicted the extent of atherosclerosis that they had. So this was kind of the first indication for us that really those exact same cardiovascular risk factors that are important for having a heart attack as an adult are also really important to us in the pediatric age group, and are things that we as pediatricians didn't spend a lot of time thinking about, but realize now that perhaps we should be. This was a subsequent study that was published in the New England Journal from the exact same group, the same cohort, except now they broadened the age range. So this was now anybody who they had a path report on from age 6 to 39. And you'll see that when you include the young adults in the study, that the intimal surface involvement was much higher than what it had been in the very young children. But the exact same pattern is true, and now it impacts not just the fatty streaks, but the presence of fibrous plaques. And so that has really contributed to our understanding of the progression of atherosclerosis in early life. I'm going to switch tacks for a little bit, and I'm going to talk about obesity. This is a study. One of the challenges we have as pediatricians is knowing when to intervene and how strongly to intervene. It was very clear in heterozygous FH that we need to do something about those high LDL cholesterol levels. It's a little bit less clear as to what should we be doing with young people that have obesity, for example. And this is a study that came out several years ago. It's a study from Israel where all of the military recruits are very well characterized. You wouldn't get approval to do this study. And you'll see the number, 37,000. And what they showed was very interesting. And I'm only going to present a tiny amount of the data, but I'm going to walk you through this slide, which I've tried to kind of simplify the point of their paper. They looked at the influence of BMI on coronary angiography. They also looked at the influence of BMI in adolescents on adult diabetes and found that that was totally dependent upon the adult BMI. So that if you had a high BMI as a child and became lean as an adult, you had no increased risk of diabetes. Unfortunately, the story for cardiovascular disease is not the same. So when they looked at coronary angiography, you'll see M1 is model 1, so that was just corrected for age. So if you had a BMI in the obese range, you had an almost 8-fold increased risk of having coronary atherosclerosis, and that was greater than 50% of your coronary vessels were occluded. When they corrected for a family history of early heart disease as well, that's M2, looks pretty much the same. You still have a 7.5-fold increased risk of having coronary disease. Now let's look at what other risk factors we have. So physical activity, blood pressure, lipids, and you'll still see about a 5.5-fold increased risk of having had a BMI in the obese range when you were a teenager. And finally, they corrected for adult BMI as well, and you'll continue to see that there's a risk that is really very high. 7-fold is extremely high. So what this tells us is that you can't wait until they get into adulthood to think about how you're actually going to assist these young people with obesity, and in particular, those who have multiple cardiovascular risk factors. So this is a study from quite a few years back. Also a longitudinal study. These studies are really hard to do. If somebody wants you to do one in a graduate, you might want to say no, because they take 20 years, and so you don't want to wait that long. And what you'll see from this study, though, that the value is that it tells us that if you had metabolic syndrome as a child, you have a 14-fold increased risk of having an MI before you turn 50. Most of the adult cardiologists' eyes grow big when I present this data, because those are huge risk factors, much bigger than the things that they normally talk about that influence cardiovascular risk. Okay. I'm going to switch gears for the last bit of this talk, and I'm going to tell you what we're doing to try and identify who those children are that we should be intervening on. And as you all know from what we've talked about today, atherosclerotic cardiovascular disease does not present like the risk factors do, but only if somebody screens for them for the most part. So people don't come to me and say, wow, I really feel like my cholesterol's high, or I feel like I have, coronary atherosclerosis, because this is not something that presents in the age group that I see. And so we're looking for tools to help us to actually try and measure atherosclerosis. And we don't have any that truly measure atherosclerosis non-invasively, and it has to be non-invasive in order to have approval to use it in kids. But we do have something called, which utilizes ultrasound to measure the thickness of the lining of the vessel. And we use the carotid. We can't get to the coronary, but you can pretty easily put an ultrasound probe on the neck and look at the carotid IMT. And a number of studies in adults have shown that the thickness of the intima media predicts cardiovascular events. And as a result of that, it's something that we are now using actively in the pediatric age group. This was a study that we did several years ago in which we started to look at this in pediatrics. We looked at 150 kids. A third of them were those with the very high LDL cholesterols I talked to you about. A third were normal, and a third had increased body mass index. And we did not see differences in the kids that were overweight. These are young children from 5 up to 18 years of age was allowed in the study. So we're looking at really early exposures. And we think that because of the age of the obese individuals that we did not see that impact yet on atherosclerosis. We did, however, see it in individuals with hypercholesterolemia. And I wanted to show you this study because this is one that sort of it follows with that. And Dr. Austin talked about the use of statins. And this was a study, one of the very few pediatric studies that has actually looked at statins and what they do to atherosclerosis in kids, or at least to IMT. And what you'll see is that after 2 years of pravastatin therapy, focusing on the right-hand side there for the combined carotid IMT, that there is lower carotid IMT in those who were treated versus those who were not in a randomized trial. This gives us great hope that we will actually be able to assist those kids that we see in our clinic moving forward. And finally, I'm going to spend the last 2 to 3 minutes talking about what are we doing now, where are we going with this information, and there are 2 studies that are actively happening here at MAC. One is called the Family Study. That's the Family Atherosclerosis Monitoring Early Life Study. And this, Dr. Teo, who's an adult cardiologist, is the PI in that study, and I'm one of the co-Is. And in this study, we have recruited 900 babies and their moms and their dads and their eldest siblings. And we are following them from pregnancy, and I feel really old when I say that they are now getting to be 10 years of age. But what we're trying to understand is what are the modifiable and non-modifiable determinants for the development of obesity and for the development of atherosclerosis in children. We have published a few studies that have looked at very early cardiovascular risk factors, and we have just begun measuring carotid IMT in these individuals, and that will happen over the next 3 to 4 years as we try to understand really the early origins of atherosclerosis outside of clinical populations. And the last study that I want to tell you about is a study, this is a multi-center study across Canada. It's called CAMPOWER, and we here at McMaster are the coordinating site. I'm the PI on this study. CIHR has funded us to try and tease apart what are the determinants for the development of obesity, and more importantly, what are the individual and family factors that actually help children to get better when they enroll in our weight management programs. And one of the sub-studies that we're doing, those are the objectives there, which I won't go into in detail, but one of the sub-studies that we are doing, and Jen Lee is involved with, is actually looking at the carotid IMT. We are looking at baseline to see what is it in obese children that predicts the extent of atherosclerosis measured this way, and also importantly, trying to understand the progression of that over 2 years and what factors contribute to that. So I just wanted to conclude. I think I probably made my point fairly clear that atherosclerosis is a process that begins very early in life. And although it doesn't present clinically, it's still important that we understand its progress, its process, and its extent of progression, and also that we can spend some time trying to figure out how to actually prevent that progression. And in order to do that, we need biomarkers. So I was excited to see the last slides that Dr. Austin presented on perhaps new ways of identifying biomarkers for atherosclerotic burden. And I think I'm going to close there, and we'll be taking